Welcome everyone to the Canadian Diabetes Association's 2016 webinar series. My name is Farah Ismail and I'm a program manager for the CDA, and I will be your host this evening. We are delighted that you're able to join us today for our webinar to learn about diabetes, sexual health, and you. Now, to start off, I would like to draw your attention to our survey. It's located at the top right-hand section of your screen. In order for CDA to better serve your needs, we kindly ask that you provide us with your input by completing the survey towards the end of the presentation, and we thank you in advance for your input. Throughout the presentation, you will have the opportunity to ask questions, and this can be done by simply typing in the question and answer box, which is located towards the bottom right-hand section of your screen, and our presenter will be happy to answer your questions at the end of the presentation. As well, we will be displaying a few polling questions throughout the presentation and would love for your participation. Please note that these questions will remain completely anonymous. Also note that you are able to customize your screens. This can be done by simply dragging down the bottom right-hand corner of each of the webinar pods to either expand or collapse each of the screens that you see. Our presentation today will last about 40 to 45 minutes in length, and we'll have about 10 to 15 minutes left at the end for questions. We will be posting this webinar on our website at a later date, should you wish to participate in it or review it again. So now I'd like to welcome our speaker, Dr. Adam Millar, and thank him for joining us today. But before turning it over to Dr. Millar, I'd like to give you a brief introduction. Dr. Adam Millar is an assistant professor and clinician teacher in the Division of Endocrinology and Metabolism at Mount Sinai Hospital. Dr. Millar is a general endocrinologist with clinical expertise in andrology and is the only endocrinologist in the University of Toronto system with this focus. A wide range of andrologic conditions are managed in Dr. Millar's andrology clinics, including male hypogonadism, infertility, sexual dysfunction, disorders of sexual development, and gynecomastia. For more information on Dr. Millar, please read the speaker bio section, and that's located on the left-hand section of your screen. So without further ado, I present to you Dr. Adam Millar.
Thank you everyone for attending our webinar tonight. My name is Adam Millar, and I'm here to speak to you today about sexual dysfunction and diabetes. Start off with our objectives for this evening. They are, as you see here, to outline the types of male and female sexual dysfunction seen in people with diabetes, to understand how diabetes can contribute to sexual dysfunction, to understand what questions, examinations, and tests may be conducted during a sexual health exam, and to describe the treatment options available for people with sexual dysfunction. This is how I hope to achieve those objectives, starting off with a description of the role of diabetes in sexual dysfunction. Then we'll move on to focus specifically on male sexual dysfunction, starting off with a description of erectile dysfunction, its causes, and treatment options. We'll touch on testosterone therapy, what its indications are. We'll then discuss low libido or reduced sex drive, and move on to ejaculatory dysfunction. From there, we'll close off today's webinar on female sexual dysfunction. We like to start off by getting a sense as to who's participating in our webinars. So I would like to ask everyone, how are you affected by diabetes? Do you have type 1 or type 2 diabetes? Are you at risk of diabetes? Are you a caregiver? Or are you a healthcare professional? I'll give you a few seconds to gather your thoughts and submit your answers. Okay, so this is interesting. We did an earlier webinar today, and that was majority healthcare professionals, whereas I see here we have majority of people with diabetes, mostly type 2, but a good representation of people with type 1 as well. Excellent. So we'll start by talking about the role of diabetes in men. We know from studies that men who have diabetes are 3 times more likely to develop erectile dysfunction than men who don't have diabetes. We also find that they tend to develop erectile dysfunction about 10 years earlier than their peers. Several things can affect the severity of erectile dysfunction. This includes increased age, increased duration of diabetes, having poor blood sugar control, and the presence of microvascular complications, so issues affecting one's eyes, kidneys, or nerve sensation. What about the role of diabetes in women? We know that female sexual dysfunction is much more common in women with diabetes. Furthermore, it can affect multiple aspects of the sexual response cycle, including arousal, excitement, satisfaction, lubrication, and the ability to achieve orgasm. Women with diabetes also can complain of pain during intercourse due to vaginal dryness. Another important thing that we can't forget is that sexual dysfunction impacts the quality of life of both men and women. Studies have shown that people who have sexual dysfunction have lower confidence, have lower self-esteem, and tend to display a lot of symptoms associated with depression. This is a component of sexual dysfunction that we can't forget about. One of the main messages I want you to get from our webinar tonight is that communication really is key when talking about sexual dysfunction, both in initiating investigations and subsequent treatment. We know from studies that many people are reluctant to discuss sexual health with their physicians. In fact, we have studies showing that over 70% of people felt that it would be embarrassing to discuss sexual problems with their doctor. The interesting thing to note, however, is that 80% of patients with erectile dysfunction would welcome discussion. In fact, most would prefer that their doctor broach the subject. The problem we have is that doctors don't do a very good job about asking their patients about sexual health. One study that looked at family physicians found that only 15.5% of them asked their patients about sexual dysfunction. There's a lot of barriers that exist in regards to communication. We know that a lot of medical practices are very busy and there's not a lot of time in a medical appointment. This can lead to a lack of opportunity to raise these issues in the first place. Many people have a sense of embarrassment or shame about speaking about sexual dysfunction, and indeed there's a societal taboo about discussing these issues openly. Some people may have pessimism about the outcome of a discussion. They may think to themselves, what's the point of bringing up something? I don't think there would be any viable therapy for it. Some people are uncertain if sexual problems are even within the realm of physician-led care. Or people may wonder what specialty treats their sexual issues. Should they be speaking to their family physician, their endocrinologist, or should it be a urologist or a gynecologist? All these factors lead to people withholding information or not disclosing information about their sexual health overall. So at the risk of sounding cliche, it really is vital that you talk to your doctor if you have any sexual dysfunction or think you may be developing some of the symptoms that we'll discuss later. If we don't talk about this, then we'll never initiate those investigations and we can never start a treatment course. We're going to shift our focus to male sexual dysfunction, starting off specifically with erectile dysfunction. Presently is defined as the inability to achieve and maintain an erection sufficient for satisfactory sexual function. Some of you may be more familiar with the term impotence. However, that's fallen out of favor over the last few years. I'm going to get everyone involved in another audience question. Which of the following features is a risk factor for erectile dysfunction? Is it age, diabetes, high blood pressure, high cholesterol, or all of the above? I'll give you a few seconds to submit your answers. Excellent. So 97.3% think that all of the above are risk factors. This is true. All of the above not only are risk factors for erectile dysfunction, but also risk factors for vascular or blood vessel health in general. When we talk about erectile dysfunction, a very important feature of this is getting adequate blood flow to the penis and keeping that blood within the penis to sustain that erection. So good job, everyone. Let's talk a little bit more about the causes. So we mentioned that decreased blood flow can be a cause of erectile dysfunction, but nerve damage can as well. You need that nerve sensation to be able to produce an adequate erection. Both nerve damage and decreased blood flow can be related to diabetes, and specifically are linked to chronically elevated blood sugars. But it's important to realize that it's not just blood sugar that manages erectile function. There's other features at play. Many individuals with diabetes use medications such as blood pressure pills, which can affect blood flow, and antidepressant pills, especially the class of drugs called SSRIs, which are well known to cause various forms of sexual dysfunction. There's also many psychologic features that contribute. Individuals who have depression or anxiety are known to have issues with erectile function. There's also situational issues that can contribute. Some men may have concerns about anticipatory anxiety, which can lead to erectile dysfunction. Other men may have relationship issues that are preventing adequate erectile function. I even have some men in my clinics who have developed erectile dysfunction after the stress of trying to achieve fertility with their partner. When you speak to your physician about erectile dysfunction, you should realize that they'll likely ask you a few important questions and perform a focused physical exam. In fact, most of the important information about sexual dysfunction is obtained from these two features. Some of the questions you could be asked is, what is the primary concern? And this is important because it may not just be erectile dysfunction. It could be low libido. It could be ejaculatory dysfunction. It could be other features of the sexual response cycle. It's important to understand when the dysfunction started. Was it sudden onset or did it come on gradually? This can help your physician try to determine what the underlying cause could be. It's important to know if anything makes it better or worse. For example, is it better with a specific partner? Is it worse when you're taking certain medications? Another thing to know is whether there's been any changes to your health. Have there been any new medications like antidepressants, blood pressure pills, or opiate-based pain medications, for example? Are there any new relationship issues? Are there any new stresses in your life, such as loss of a loved one, stress at the job, or otherwise? Physical exam usually will start as a general exam looking at features like blood pressure, pulses, heart rate, heart sounds, and then we'll usually focus more on features such as the penis, looking for any structural abnormalities, and the testes in regards to size and any textural changes. Doctor may also want to do some blood tests as well. Most commonly what's checked are blood sugar levels and cholesterol levels. Both of these aspects can affect vascular health and blood flow, which, as we learned before, contributes to erections. You may notice that there are some men's clinics around, and they may offer extra testing like ultrasounds, blood vessel studies, or response to injection therapies. Many of these are often at cost to the patient. And to be honest, they're rarely necessary. Often with a good history, physical exam, and a few baseline blood tests, that's usually enough for us to start on a trial of therapy without needing any of these other expensive and often unnecessary tests. Another test that may be done by your physician is an early morning testosterone level. I put down ×2 because it's important that we have low levels on more than one occasion to confirm that it is indeed low. As per the CDA 2013 clinical practice guidelines, it's advised that men who have both diabetes and erectile dysfunction should have their early morning testosterone levels checked, given that levels are often low in these men. So one could consider a trial of testosterone therapy if they meet the following criteria. If they have 2 low early morning testosterone levels, if they have symptoms that we'll discuss in a few slides, and if they have no other medical issues that would prevent the safe use of testosterone therapy. So talking about those signs and symptoms of low testosterone, this is a slide that shows you many of them, and I can appreciate this is a very busy slide, but I'll try to navigate us through this. There are non-sexual symptoms linked to low testosterone, such as low energy and vitality, diminished physical performance, decreased mood, impaired cognition or ability to think, and in some men, increased fatigue. Some men may note hot flushes or sweats, poor concentration and memory as well. There's also physical signs that one can see in some men with low testosterone, including increased waist circumference, decreased testicular size, reduced body hair, and male breast growth or gynecomastia. Some lab findings as well include anemia or low red blood cell count, reduced bone mineral density, and obesity. There's also sexual symptoms that you can see here circled in red. These include low sexual desire or libido, difficulty with orgasm, lack of spontaneous erections, decreased intensity of orgasm or absence of orgasm, and decreased sensitivity of the genitals. Now, there's a lot of signs and a lot of symptoms listed on this page, and an important point I want to make here is that many of the signs and symptoms you see here are not specific. So just because someone may have 1, 2, or 3 symptoms on this page doesn't necessarily mean you have low testosterone. As you could imagine, there's a lot of other medical conditions that can contribute to some of these signs and symptoms. Many of these symptoms can be seen with hypothyroidism or depression, or can be the side effect of medications. So it's important that you consider other contributing medical factors as well, and of course confirm with the low testosterone value before considering testosterone therapy. If it is deemed appropriate to proceed with testosterone therapy, then there are several options available in Canada today. Most commonly, we see patients being prescribed injections, gels that are applied to the skin, patches that go on the skin, or capsules that are ingested. We work through these one at a time. Injections are typically given by a family physician or a nurse every 1 to 2 weeks, depending on the dose. Gels that go on the skin are usually applied at home by the patient themselves. Skin patches likewise are applied by the patient every few days. The oral capsules are taken several times per day. In regards to potential benefits, really one could expect to potentially see benefits in any of the features we showed on the previous slide. The important point here is that it may help some of these symptoms. I see some men who have improvement in multiple signs and symptoms that are noted on this slide, but conversely I also have men who've tried testosterone and don't notice any improvement at all. So testosterone is a hormone, but it's important to remember that it's still a drug. And like any drug, it has the potential for side effects. Some of the risks associated with testosterone therapy are what you see here. A decrease in testicular size and a decrease in sperm count. So it's important that men who are trying for fertility don't take testosterone, as it typically will reduce one's chances at fertility. Testosterone can cause an increase in the red blood cell number, and this could theoretically make the blood thicker and potentially predispose to clotting as well. We know that the prostate grows after testosterone is administered, but we don't believe at present that it causes prostate cancer to grow anew. We know that there are studies that show in men with metastatic prostate cancer that testosterone therapy can cause that to grow, but there are some men with prostate cancer who have been treated with testosterone therapy who haven't had any growth at all. So this really remains an area of controversy right now until we have larger studies that can confirm for us where the risk lies. Equally controversial is the issue of testosterone in the heart. There are some studies that have suggested that older men and men who have pre-existing heart disease may be more at risk of heart events or death after using testosterone. But then subsequent studies have suggested no harm. And again, until there really is a large, adequately designed study that puts this question to rest, I think this will remain a controversial topic. We're going to go back to another audience poll. Which of the following erectile dysfunction pills is the most effective? Your options are Viagra, Cialis, Vitra, or all are equally effective. I'll give you a few seconds to decide. Great. So 92% said that they're all equally effective. And I would agree with you there. I'll